So thank you, Professor Rizvi. Thank you, Professor Sharma, for inviting me. Barring the pandemic, I've been here for most of these sessions, haven't we, Anil? It's a small community. I think on some day before I retire, we get to day 3 or maybe day 2, even if we get half a session. That will be something. So I think, but we are a small crowd, and I can recognize all friends here. So thank you for giving me the opportunity to come again and talk to you a little bit about what Professor Rizvi thought I might be able to do justice to. I have a disclosure which is not listed there. I don't read my emails that well. So actually, I thought I was doing Dr. Shah's talk. It was only when I was at my mother's place 3 days ago I realized that actually I was the chairperson for that talk, and my talk was something else. So forgive me for my slides. It may not be as good as some of the slides that have preceded here. So I work in Oxford, where I was a work colleague with Professor Vaidya, who now lives out of Chennai and globetrots and goes to Cleveland Clinic and everywhere. And I'm delighted to be here in the Pink City, although I don't think I'll get much of a chance to see it. You can see already the trend of this talk. I'm not really talking about the talk. I'm talking primarily bullshit, but that's okay. Uh, so this was the brief given to me by Professor Rizvi. We all know it's not an uncommon scenario, and I think all of you have discussed that pancreas transplant was beset with a lot of problems as it started. And some of you have mentioned that we've got better over the years. Our surgical techniques have improved, our perioperative care has improved, our immunosuppression has improved. So we have caught up with the other organs in terms of our success rate. But we still have situations where we end up with early graft losses. So this is where I worked. This is where Anil worked till 2015 before he left us. We are very sorry for that, Anil. If you would like to come back, maybe we would welcome you. You may just have gone, maybe you are coming up to the pensionable age, so maybe you may not be there. So this is what we've done so far. So this is a little app designed by one of my colleagues who shares my office. He's a complete nerd. And so we've done 1,231 pancreas transplants so far. So Anil has contributed to the first 10, 12 years of it, and I've been associated with it for nearly 20 years. So that's sort of the split of the numbers that we've done. And we do come across elevated pancreatic enzymes in the post-op care of our patients. So how do we look after our patients? Dr. Vaidya was a big champion of putting in drains. I'm not such a great champion for putting in drains, but I do put drains into a pancreas because we found that the drain fluid amylase actually does give you some ideas with regards to how your graft's going to do. Of course, serum amylase and lipase. And if either of those are raised, then we in Oxford do, unlike Ahmedabad and PGI, where your ultrasonographers are so good that they're able to tell you whether your portal vein is still flowing and your Y graft is still intact. Our ultrasonographers are rubbish, or our radiologists are rubbish. We have to put them through a CTA. And the CTA often reveals things like peripancreatic fluid collections, etc., etc. In this situation, if we are dealing with what we think is a rejection, then DSA monitoring is reasonable. A kidney graft biopsy is reasonable. And we unfortunately still rely on empirical therapy in situations like this. The reason I'm talking about this is early drain fluid amylase rises or elevations in serum amylase and lipase do give you indicators that there may be something wrong with your graft, which allows you for an early and prompt intervention, which might lead you to salvage that graft. So that is truly relevant, but this is sort of what we do. But in Oxford, we like to fly blind. We have not done a single pancreatic biopsy as yet, believe it or not, barring the bladder drained ones. And I don't know where Suresh, was it Suresh you said bladder drain should be banned? Professor Vaidya did the first one in 2007, and we had such poor results with our PTAs that we've switched to the bladder drain pancreas transplant alone. And believe it or not, there's a slight trend in improved survival in this group, particularly if you get the graft through for the first years. Yes, 50% of them have terrible symptoms, and a vast majority of them would require an entry conversion, but it does help. But we like to fly blind. We just don't know what's happening with our patients. If the if the amylase and amylase and lipase goes up, we do a CT scan. If nothing is wrong with that, the graft looks a bit inflamed, we might just give them empirical steroids. We might do a kidney graft, and if the kidney graft shows that nothing's wrong with the creatinine's okay, we might still give them graft there. So unlike the Odrico group and Madison group, which Dr. Shah worked in, we have never done a pancreatic biopsy today. Duodenal biopsies we've been doing, and that's one advantage, Suresh, of putting it into the bladder, because you can biopsy the duodenal. Although it's a disparate organ, comes out from has a completely different embryology, but it can give you. And 21.2% of these bladder drain cohort have had rejection at some in time points, and we've done now more than 100 bladder drain pancreas. So it's a substantial number. Concurrent kidney biopsy is something that we do. I just looked at the literature. So I said, well, let me find out if anyone else. We in Oxford are not very prolific in writing things. We've not written much about what we do. But this is the Madison group, and they basically looked at their experience over a 10-year period of what does elevated amylase and lipase means in these patients. And essentially, they said what I just said, is that it gives you a little marker as to whether there is something wrong which you can mitigate against. So over a 10-year period, they did 443 transplants. We think we did twice that number. And then they found that increase in enzymes at day 1 and day 5 were associated with increased early graft loss by pancreatectomy, fluid collections, which you addressed one way or another, bleeding and thrombosis. So just to reiterate, early enzyme rise merits diagnostic workup and an early intervention to mitigate against detrimental outcomes. Late elevation serum amylase, generally in the setting of a nephrology clinic. Again, you go through the same diagnostic pathway of imaging. You might find a swollen graft. If your center doesn't do biopsies, and if there are problems with the kidney, you can biopsy the kidney. Or if your sugars are a little bit labile, you can just put them on some steroids, or if they are unresponsive, you can try some ATG. But we like to fly blind. There's a very small Japanese study, and it's interesting how people who are prolific in writing can write a lot. So they had 69 patients, and 16% of their patients had elevated enzymes. And in their multivariate analysis of this small cohort, they also found that it's associated with increased early complications. So part of the brief that Jamal had given me was, what should the workup be? So the workup in a setting like PGI or IKDRC, it's a duplex scan where you can look at the flow and whether there is either good flow into the graft. This is early on, I'm saying, whether it's a peripancreatic fluid collection, whether your radiologist tells you whether it's an anastomotic leak or not, I don't know, but all of those situations require an urgent surgical radiological intervention. In our centers, our radiologists are not skilled, so we go to a CTA, and depending on what we find, we then do a surgical or radiological intervention. Pancreatic graft biopsies in centers which do this, particularly where you've ruled out graft pancreatitis or you cannot rule out graft pancreatitis, is the gold standard, and you can do it many ways, and it's been described, ultrasound, CT guided, and some people even put the scope in and do it, and you then diagnose your rejection and you treat it appropriately. There's a very large group of indeterminate. In Oxford, we don't have a pathologist who can interpret our biopsies. So even if we set up the infrastructure and we put our hand on our hearts, we wouldn't be able to support it. I just tried to look at what is the international clinical monitoring for pancreas transplant. It's relevant to know what do others do. And these guys surveyed, and Anil would recognize George Burke there from Miami and a few other people there. Sorry? Thierry Bernie as well from Zurich and others. Bob Strata. So, a good job as to how are people doing it. Unlike the Oxford guys, are they flying blind or not? So this included 24 pancreas units and 18 islet units, and they basically looked what was their protocol monitoring and what was their for-cause monitoring. And this is what they are doing. So annually, everyone is doing what all of us do: lipase, amylase, HbA1c at clinics, visits, fasting glucose, C-peptide. Sorry, I skipped it. And then that was strongly recommended. Suggested was DSA, and I think Ashish Sharma was asking, if you find a DSA and it's increased, what will you do about it? Most of us will just ignore it if everything else looks okay. So I think most of us do this in our clinics. It's not very different, although only 24 centers responded to that. For cause monitoring is more or less the same, except they have added autoantibodies and then have added a pancreas biopsy, which is suggested. I know in my country, sorry, not my country, my country of work, it's the Manchester unit which occasionally does it. It's the Cardiff unit which occasionally does it, and it's the Guy's unit which does it occasionally. The other 6 centers don't do it. We certainly don't do it. So this is how people do for cause monitoring. But as you can see, pancreas biopsy gives you an idea as to what's going on. So just to conclude, and I'm sorry if it's not been very enlightening, it's not an uncommon situation. We do come across this, particularly in the drain fluid amylase. If it is up, you probably have a micro leak, which hopefully, if it's not making your patient unwell, will settle down and will get better. If it is very high, then you probably have a situation with graft pancreatitis. Clear link with early complications, as I've already said. It requires us to intervene quickly. I think Anil and I went through a phase where we were trying to deal with some of these collections radiologically, and what we found was that these patients then lingered on for a longer time in the hospital. So it's much better to take your patient to theater and wash them out, and it doesn't matter if you have to go back to theater more than once and end up sometimes with the aphthera, etc., and a vac dressing. So there you are. That's my team. The people who have contributed greatly are towards the bottom there: Peter Friend and Anil Vaidya, who don't work with us anymore. Peter Friend has retired, and I've just gone up the league just because I'm old. Thanks very much.